Hello, my name is Jeremy. I'm with Faithful Guardian Training Center. Today we're going to be talking about the chest trauma and the anatomy associated with the chest and how they all get affected. So to start with, you need to understand what your thoracic cavity actually is for us to be able to start with chest trauma. So posteriorly, so to your back, you have your thoracic vertebrae, and you also have your ribs. To your lateral aspects, you have your ribs, and to your anterior, you have your ribs and your sternum. Superiorly, we have the thoracic inlet, which is kind of where everything enters your esophagus, your trachea, where everything decides that it wants to enter inside your chest cavity. And inferiorly, we have our diaphragm. And understanding that pocket that everything makes and how it's all built up really gives us a good understanding as to when something gets injured, what's actually happening. So you need to know that the thoracic cavity, you have 12 ribs total. And so those 12 ribs they're all going to go down the posterior aspect of your thoracic cavity. So your ribs, they actually correlate with your vertebrae. So we have 12 ribs, which means that we're going to have 12 vertebrae. So if you get asked how many thoracic vertebrae you have, the answer will be 12. The last two ribs that we have, rib 11 and 12, they're actually going to be considered our floating ribs. Ribs 1 through 10 are actually going to all correlate with the sternum, even if that means that they're connected through the costal cartilage. So you have your sternum anteriorly. You have your superior manubrium, your central sternal body, which is going to be the main brunt of your sternum. You have your suprasternal notch. That's the space directly superior to the manubrium, and then you actually have your angle of Louis, which is the junction of the manubrium to the sternal body. So it's part of the actual sternum itself. You also have our clavicles, which are those are S-shaped bones, and directly behind them and beneath them we actually have our subclavian artery and our vein. And so if your clavicles get ruptured or broken, they can actually cause a significant amount of damage on the inside, leading to hemothorax, pneumothorax, any number of issues. Now you have 5 of the 7 pairs of your ribs that they attach directly to the sternum via the costal cartilage, and then you also have an intercostal space that is between each rib. Now there's a couple different ways that you can kind of look at that space. So a lot of places they'll tell you to think about the ribs and the intercostal space as kind of like a bridge, and you have stuff water that flows under the bridge. What that means is that you actually have your nerves, your bundle of nerves, your arteries, your veins, they all go under the ribs. They are directly lying on the bottom side of the ribs. So what this means is that if we are attempting to perform a needle thoracostomy on somebody because we're suspecting a tension pneumo or a pneumothorax or something like that, if we were to go under the rib instead of over it, we would not be entering the empty space that's provided to us. We would actually be rupturing the arteries, the vessels, and the nerves that are right there, and this could have significant complications for our patient. It's just one of those things that we need to be aware of and keep in mind. So remember, water flows under the bridge, blood flows under the rib. Now we also have our mediastinum, which is essentially going to be the middle portion of the chest. So behind that, we have our heart, our great vessels, we have our esophagus, our trachea is a big one, the main stem bronchi, and you also have your vagus and your phrenic nerves. Everything really kind of lies down the center. And so if you have somebody that has a mediastinum, this means that they have air building in the center of their chest. And so something that you do have to worry about, with the higher injury. So for example, if you have somebody that broke their first or second rib, those are very, very stout, very strong ribs, strong bones. And so if they get ruptured or damaged, and where they have a break, you can actually have a higher incidence of great vessel disruption, so aortic disruption. And so this can be an aortic rupture, it can be a contusion. It's just one of those things that you need to be aware of. That's a thing. Now, your heart is also lying directly in the mediastinum, and your heart is inferior to your ascending aorta, and it's going to lie pretty much about right there about your nipple line, 4th, 5th intercostal space area. And so it's composed of a couple different things. So you have your pericardium, or your pericardial sac. Your pericardial sac is actually going to be the outermost layer of everything that's going on. Now, your pericardium, it actually is going to attach to the diaphragm and the surrounding structures to kind of help create an anchor for everything. Now, inside of that pericardial sac, you will have your heart, okay? And so that's going to be your actual heart muscle. So as your heart is beating, contracting, is doing everything inside of that sac. And so an example of something that could cause damage to that area, or something that would be negative to that area, would be a pericardial tamponade, which is where you have blood or a fluid leaking inside of that pericardial sac. And then what happens is, as your heart continues to beat, it is releasing more fluid, is releasing more blood into that fixed size container of the pericardial sac, which leaves your heart less and less room to be able to contract and relax. And so eventually it's going to get to a point where there's so much fluid, there's so much of a substance built up inside that pericardial sac that it is actually going to cause your heart to stop beating. And so the fix for that is actually going to be a pericardial centesis, which we will talk about later. Now, most of your heart is actually going to be protected anteriorly by the sternum, and you can feel that beat if you were to place your hand on somebody's chest, and right there, about that 5th intercostal space, right there by the sternum, you'll be able to feel their heart actually beat against their chest. After the blood leaves your left ventricle, leaves your heart, it's going to enter the aortic, the ascending aorta. The ascending aorta is going to be your aortic arch, and then after that, it's going to be breaking off into all of your other vessels, your subclavian, your brachiocephalic. Everything's just going to kind of branch off of each other. And then that's also going to go down to, you have your thoracic aorta, and then you eventually get into your abdominal aorta as well. And your thoracic cavity, your chest cavity, is going to comprise a lot of those great vessels. And the closer the vessel is to the heart, really the bigger it is. So your aorta is the greatest vessel that we have. And so if it were to get ruptured, get damaged, or anything like that, there's a very high incidence of death just from blood loss alone. And what they're finding is that most traumatic deaths from car crashes, for example, where you have somebody that is in cardiac arrest on scene, is typically going to be due to aortic rupture or aortic dissection on scene. Now, aside from your heart and your aorta and your vessels, you also have your lungs. So the lungs take up a very, very large portion of your chest cavity. And so this is going to be on your left lung. We're going to have 3 lobes. Your right lung is actually going to have 2 lobes. And so we're going to redact the previous 30 seconds because I definitely just misspoke. So you also have your lungs, which occupy your thoracic cavity. So for example, your left lung is actually going to contain 2 lobes. And it contains 2 lobes as it's trying to make room for your heart, so to speak. And your right lung, your heart isn't predominantly to the right, so it's actually going to have 3 lobes. So 3 lobes on the right, 2 lobes on the left. The right side of your heart, your right atrium to your right ventricle, also contains your tricuspid. So if you want to think about it as, tricuspid has 3 points. Your right lung, as with the right side of your heart, contains 3 lobes. Now, your diaphragm is going to be one of those things that is very, very important to your chest cavity. So your diaphragm actually attaches anteriorly, so to the front part of your chest, at about the 5th or 6th intercostal space. So that's just below the nipple line. And as we breathe in, our diaphragm is going to descend as it allows room for air, and as we inhale or exhale, our diaphragm is going to ascend, making our thoracic cavity actually smaller. So if you have somebody that has a chest injury that is nipple line or below, it can actually be considered both a thoracic trauma and abdominal trauma due to the diaphragm. Now, posteriorly, your diaphragm connects to your ribs at about the 12th rib. And so your diaphragm is actually going to be the primary muscle of breathing. So, and it's innervated by something that's called the phrenic nerve. And the phrenic nerve, it's really, it gets a lot of its, your diaphragm is innervated by something called the phrenic nerve. And your spinal column, it has these nerves that branch off of it in C3, C4, C5. Those are the vertebrae where the spinal column, where if they get damaged, your diaphragm will actually stop and cease breathing. So, for example, if you have somebody that has a C3 fracture, they can be completely awake. They can be paralyzed from the neck down and have an inability to breathe, and due to the diaphragm and the intercostal muscles not being able to contract. And so if you leave this patient alone, they're going to die from suffocation, essentially, because their diaphragm's not going to be able to move. But these patients can be brought back. They're going to go into a hypoxic arrest if they go down for this isolated reason. And these are your patients that you may see who, a couple years down the line, they're ventilator dependent, they're stuck at home on a vent, their family will typically know how to take care of them. So some of the primary functions of the thoracic cavity and its contents is going to be, it deals with oxygen exchange and getting the oxygen and the other nutrients exactly where it needs to go. So it's all about maintaining oxygenation and maintaining circulation. So your brain is going to help with all that because you have these chemo receptors that are going to be located in the carotid sinus and the carotid arch, and they're going to help regulate everything based off your CO2. So if your CO2 gets too high, the receptors are going to send in a message to your brain telling your brain to say, hey, I need to breathe a little bit more or breathe a little faster because I'm having too much CO2, which is putting too little oxygen. Right? Now, the intercostal and the accessory muscles, they pull the chest wall out and away from the center of the body as the diaphragm contracts downwards. And so whenever you think of a muscle that's contracting, you typically think of things getting smaller. But it's opposite in the chest, if you want to look at it like that. So for example, your diaphragm, whenever it contracts, it goes down. Whenever your intercostal muscles contract, they go out. Okay? And that is just all to help facilitate the negative pressure that is getting created inside of your chest to be able to pull air in. Now, blood is going to be delivered to your body through your alveoli or through your circulatory system, and that blood is going to get oxygenated through the alveoli. The alveoli and the alveoli capillaries, all that takes place in the lungs, and that's actually going to be part of your external respiration because you have air that is being brought in from the outside, and you have gas exchange right there at the alveoli. And so whenever you have So a big part of oxygenation is actually getting the oxygen down to the alveoli to begin with to be able to facilitate that gas exchange. Um, so, and that after that gas exchange, you have your blood vessels that will carry the oxygenated blood and carry those nutrients to wherever it is they need to go. Now, so you have ventilation, oxygenation, and respiration. So ventilation is going to be the physical movement of air in and out. Oxygenation is going to be the onloading of oxygen onto somebody. And then you have respiration, which is the actual exchange of the gases at the alveoli. So, for example, your oxygen being brought in from the outside and us exhaling CO2. That is an example of respiration. Now, for all this stuff to work, your heart has to be properly functioning as well. So as blood is returning from the body, so it's going to be deoxygenated. It gets pumped through the right atrium to the right ventricle to the lungs where it goes to that alveoli process. It goes through your pulmonary vein back to your left atrium to your left ventricle, which gets pumped out. The blood gets pumped out to your rest of your body through your aorta. And a big factor in this is going to be cardiac output. So if you have anything that's going to compromise that, it's compromising your cardiac output, which is compromising your ability to oxygenate, which is compromising the ability of cellular respiration, and is ultimately going to lead to a state of hypoperfusion, potentially by hypoxia. And it's all about how you are managing that patient. We can cut the previous 10 seconds out. Big thing about cardiac output that you need to understand is it is measured by stroke volume times heart rate. Your stroke volume is how much is actually pumped out at one time, and your heart rate is your heart rate. How many times does your heart beat in that minute? So, for example, if you have somebody that has a heart rate of 100 and a stroke volume of 50 milliliters, which means that at every time that their heart pumps, it's pumping out 50 milliliters. Okay, if you have somebody who has a heart rate of 100, that's actually going to put your cardiac output at 5,000 milliliters or 5 liters.